Hello everyone, my name is Ziad Ali from St. Francis Hospital and Heart Center and the Cardiovascular Research Foundation, and I'm going to be talking to you about the impact of COVID-19 on STEMI management. These are my relevant disclosures. We're going to be focusing on two cases to sort of highlight some of the issues that came up with STEMI management during COVID-19. The first patient is a 78-year-old female with a past medical history of hypertension who presented with shortness of breath and dizziness for 1 week to her primary care physician. The initial oxygen saturation at the clinic visit was very low, reportedly 44%, and she was referred to the emergency department. The patient was diagnosed as having COVID-19 and treated with non-invasive positive pressure ventilation. On the second day of her hospitalization, she developed bradycardia and hypotension in the ICU, requiring intubation. An initial troponin measurement of 0.306 was made. This was her EKG. A close analysis of the EKG shows EKG findings consistent with ischemia, particularly in the lateral leads where there is significant ST elevation. More so, in V1, we also see significant ST segment changes, but perhaps also an area of PR depression. Thus, the diagnosis is likely, or differential diagnosis includes pericarditis, but also ischemia. However, subsequently, the patient develops worsening EKG findings and symptoms, and the STEMI code is activated. Prior to transfer to the cardiac catheterization laboratory, the patient develops pulseless ventricular tachycardia requiring ACLS protocol, and return of spontaneous circulation was obtained after 10 minutes. Thus, the diagnosis previously of potential myocarditis is now shifting more towards one of an acute coronary syndrome that requires urgent evaluation. The patient has cardiac arrest, CPR is performed, ROSC is achieved. Following this, with a short period of recovery allowed for normalization of the EKG has dramatically changed to show what appears to be tombstone ST elevations, and this type of dynamic change would essentially exclude myopericarditis and strongly indicate acute coronary syndrome with ST elevation myocardial infarction and complete occlusion of a major epicardial coronary artery. So the patient undergoes evaluation. Cardiac catheterization reveals a relatively normal right coronary artery with non-obstructive minimal disease and excellent blush. Coronary angiography of the circumflex coronary artery also reveals non-obstructive or near normal coronary arteries in the circumflex. In the left anterior descending, there is some tortuosity and a large septal branch. However, there is absence of any significant coronary artery disease. Another view of the left anterior descending confirms that we're not missing a left main lesion or a proximal LAD lesion, which may have otherwise been hidden in coronary angiography. Closer evaluation of the left main, given the patient's severe EKG changes, really doesn't identify any obstructive coronary artery disease at all. So coronary angiography demonstrated normal coronary arteries. The ST elevations on EKG and cardiac arrest were attributed to COVID-19 myocarditis, and the patient actually made a recovery and was discharged to a rehabilitation facility after 6 weeks of inpatient treatment. Let's go to case 2. This is a 38-year-old male, known past medical history, presents to the emergency department via the emergency medical services with a complaint of chest pain for 4 hours. The pain is described as burning that localizes to the middle of the epigastrium and travels to the chest. The pain began after eating pasta for dinner, And family history is notable for early coronary artery disease in both parents. He endorsed 1 pack per day of cigarette use. Vitals show mild fever and stable hemodynamics, mild cough that he attributes to gastroesophageal reflux disease. Now, importantly, both of these patients actually presented on the same day. So the previous patient, who turned out to have myopericarditis, had only been treated several hours prior to this patient coming to the emergency department. And the initial EKG demonstrates sinus rhythm with frequent PVCs in a bigeminy pattern. And of course, it's difficult to determine whether or not there's any clear ischemia here because the wide QRS complex will create potentially an artifact of ST elevation. Of course, is not reliable for determination of ischemia because of the wide complex. So the patient undergoes a coronary CTA, which is negative. The patient undergoes cardiac enzyme evaluation, which is also negative. But the patient does develop worsening chest discomfort. And by the time that the patient has now arrived, and there is some question where the patient might be COVID, he ends up having a negative COVID study. But now, at 4:14 a.m., the bigeminy appears to have resolved, and the ST elevations appear to be more pronounced, even though there is somewhat of an interventricular conduction delay. There are not significant reciprocal changes, but there is, of course, what appears to be either J-point elevation or anterior ST elevation in leads V2 to V4. The right coronary artery is clearly non-dominant and free of obstructive disease. The circumflex coronary artery is a large dominant vessel with 2 obtuse marginal branches and either a left posterolateral or left posterior descending artery, more likely the posterolateral because of the absence of septals, which is also really non-obstructive. In fact, it appears largely normal. Another view shows the circumflex in really a normal appearing state, and it looks like perhaps because of this large dominant circumflex that there may be a diminutive left anterior descending, at least in this view. Again, it appears that this large left anterior descending, which is reaching the apex, is likely diminutive. But something peculiar shows up on this angiogram. There is an absence of septals on this branch, which starts one to consider whether this actually could be a diagonal branch. And this highlights the critical importance of high quality diagnostic angiography. Because when we perform a left main intervention, we see that where the left anterior descending should be, which is going upwards and to the left of the screen, really there is nothing. And we are still somewhat mimicked by the fact that there's a large left dominant system, but there are really no branches going to the septals. And then an angiogram finally reveals an absolute and complete occlusion of the proximal left anterior descending with one septal branch actually reaching downwards. Through quite a difficult intervention, we're finally able to cross this proximal LAD lesion and protect the diagonal branch. Reestablish flow. Clearly there's a dissection at the proximal part of the left anterior descending, which is probably a combination of thrombus and dissection. And a stent is placed proximally and then further optimized with the final result showing slow flow in the LAD consistent with a missed infarct. Unfortunately, this had some significant consequence for the patient because there's a significant detriment to the patient's ventricular function. The aortic valve appears to be normal. However, there is almost complete akinesis of the anterior wall. Definitive contrast confirms the absence of a intracavitary thrombus. The post-revascularization EKG the following day after the patient's STEMI actually unfortunately shows deep R waves consistent with an anterior myocardial infarction that has been completed. The patient was discharged on hospital day 3 after being fitted for a life vest and started on heart failure medications. The patient ceased use of cigarettes. He had one additional episode of chest pain prompting him to present to the emergency department, for which he was treated medically. COVID-19 has had a major impact on the management of acute coronary syndromes. In this study published in JACC, what you can see is that the impact of the coronavirus disease pandemic on primary PCI interventional cases is a significant reduction in the total number of cases that were treated, and more so a significant increase in the time to treatment. Now, of course, these are clearly related to COVID because of important things such as PPI, also related to things such as cath lab activation and workflow. And so what you can see is that from February 23rd, 2020, here to 29th of March, there is a dramatic reduction in the diagnosis of acute myocardial infarction and STEMI. And in fact, if we look at the initial outcomes from the North American COVID myocardial infarction registry, what we see is that in the patients who have COVID-19, the in-hospital mortality is actually very high. The length of stay is longer and the ICU stay is longer. And that all is consistent with basically the biology of COVID. So in conclusion, COVID-19 has impacted the way we manage STEMI by acting as a great mimic. And I think what I showed you in these two cases is that STEMI is usually something that is easily diagnosed based on EKG and symptoms. However, when we have to take into account other uncertainties, such as the possibility of myopericarditis, such as exposure of staff to patients who are COVID positive, where the diagnosis may be uncertain, we deviate from the normal pathways which we have shown to improve patient outcomes, including doing pre-procedural echocardiography, delaying the time to the cath lab. And of course, there is a hesitancy to take patients to the lab due to the fear of exposure, and also hesitancy for the patients to actually come to the hospital even if they're developing chest pain. This is compounded by poor diagnostic discrimination from screening tests such as clinical history, EKG, and echo. So in summary, I'd like to suggest to you that COVID-19 impacted STEMI management by acting as the great mimic. And these two cases, which happened on the same day, actually showed how the first case we were for sure thought it was going to be a STEMI actually ended up not being a STEMI and being myopericarditis, even though all the classic signs were there. And on the contrary, a patient where we were concerned they may have COVID and waited for their COVID their COVID antibody testing, PCR testing, we actually ended up missing that patient's diagnosis and paying more attention to other things other than the EKG and the chest pain symptoms the patient was having. Thank you very much. I hope you enjoy the rest of the conference.